Today's topic is congenital heart disease. Etiology caused by developmental abnormality, genetic abnormalities, genetic factor, chromosomal abnormalities and outflow tract defect, environmental factors such as congenital infection or teratogen, multifactorial like genetic, environmental and maternal factor. The risk of recurrence of congenital heart disease increase if a first degree relative is affected. Chromosome abnormalities, Down syndrome associated with AVSD and VSD, trisomy 13 and 18 associated with VSD and PDA, Turner syndrome associated with coarctation of aorta, Marfan syndrome associated with aortic aneurysm and MPP, teratogen infection like rubella associated with PDA and peripheral pulmonary stenosis, drug like dilatin associated with PS and AS, lithium associated with Epstein anomaly, alcohol associated with VSD and ASD, retinoic acid associated with interrupted aortic arch, TGA and TOF, maternal disease like diabetes associated with TGA, VSD and cardiomyopathy, SLE associated with complete AV block. Congenital heart disease, two types, cyanotic and acyanotic. Divided in three major categories: left to right shunt, right to left shunt, and obstruction. A shunt is an abnormal communication between chambers or blood vessel. Direction and magnitude of shunt depend on size of defect, relative pulmonary and systemic pressure and resistance. Acyanotic congenital heart disease. First, atrial septal defect. 5 to 10% of total congenital heart disease, two-fold of female than male. Three types exist: primum, secundum, and sinus venosus. The most common is the secundum type. Clinical manifestation: most are asymptomatic. Right ventricular lift, wide and fixed split of second heart sound, systolic ejection murmur, mid diastolic murmur at tricuspid area, holocystic murmur at mitral area. Diagnosis: clinically in chest X-ray, right ventricle and artery enlargement, large pulmonary artery, increased pulmonary vascularity, ECG, volume overloaded, right axis deviation, minor right ventricular conduction delay, echocardiography and catheterization. Prognosis well tolerated. Complication: pulmonary hypertension and Asperger syndrome. Treatment: surgery for all symptomatic ASD. Asymptomatic patient with shunt ratio more than 2:1. Ventricular septal defect, most common of congenital heart disease. Type of VSD: subpulmonic VSD, perimembranous VSD, inlet VSD, and muscular VSD. Clinical presentation depend on VSD size and pulmonary vascular resistance. Small VSD generally asymptomatic. VSD can detect murmur in first or second week after birth, pansystolic murmur at left lower parasternal border. In moderate to large VSD, developed heart failure in 1 to 2 months, murmur same as small VSD and loud P2, Asperger complex. Diagnosis: clinically or chest X-ray shows cardiomegaly and plethoric lung, ECG, echocardiography. Prognosis: 30 to 50% a small defect close by 2 years of age, rarely moderate to large defect close. Treatment: medical management, digoxin and diuretics, adequate nutrition, high calorie formula or breast milk, supplemental tube feeding, prophylactic antibiotic to prevent bacterial endocarditis, surgical repair, and interventional cardiac catheterization. Atrioventricular septal defect, endocardial cushion defect, 4 to 5% of total congenital heart disease. Clinical presentation: in partial and intermediate AVSD can be developed heart failure in infant, cardiac murmur, systolic ejection murmur, widely fixed split S2, pansystolic murmur at apex. Complete AVSD within 4 to 8 weeks after birth can be developed heart failure. Cardiac murmur same as above and loud P2. Patent ductus arteriosus, 9 to 12% of total congenital heart disease, twofold of prevalence in female than male, 80% of low birth weight in Many children, there is no known reason for the ductus arteriosus remaining open. However, PDA is seen more often in premature infant and infant born to mother who had rubella during first trimester of pregnancy. Pathology: deficiency of mucoid endothelial layers and muscular media in term infant. Signs and symptoms: fatigue, sweating, tachypnea, shortness of breath, congested breath, disinterested in feeding or tiring while feeding, poor weight gain, murmur, increased systolic BP, bounding pulse. Diagnosis: clinically, chest X-ray, ECG, echocardiography. Prognosis: small PDA with normal life, large PDA cause congestive heart failure, complication infective endocarditis, congestive heart failure, embolization and pulmonary hypertension. Treatment: medical and surgical closure. Obstructive lesion: pulmonary stenosis, 4 type: valvular, infundibular, supravalvular and peripheral. Pathophysiology: right outlet obstruction cause pressure which cause right ventricular hypertrophy. Clinical manifestation: in mild to moderate asymptomatic critical in mild to moderate patient is asymptomatic, and in critical stenosis, systolic ejection murmur, heart failure in neonates and infants, rarely cyanosis. Diagnosis: clinically, chest X-ray, right ventricular hypertrophy, reduced pulmonary blood flow, ECG, echocardiogram. Prognosis: good in mild to moderate. Complication: congestive heart failure and severe pulmonary stenosis and rarely infective endocarditis. Treatment: in valvular PS, balloon valvuloplastics and surgery. Aortic stenosis: valvular is most common. Other type is supravalvular and subvalvular. Clinical manifestation: in mild stenosis, normal pulse and apical impulse, systolic ejection murmur, normal to enlarged heart size. Critical stenosis: left ventricular failure, pulmonary edema, cardiomegaly, weak peripheral pulse, weak systolic murmur, paradoxically split second heart sound. Diagnosis: clinically, chest X-ray, ECG, echocardiographic, graded exercise testing. Prognosis is good for mild to moderate. Treatment: balloon valvuloplasty and surgical. Correction of aorta: 6 to 8% of total congenital heart disease, twofold of prevalence in male than female, 35% is associated with Turner syndrome. Type of correction of aorta is simple or complex. Simple is associated with PDA and complex associated with other congenital disease. Clinical presentation depend on severity of stenosis and other congenital heart disease. Critical coarctation of aorta: shock, hypotension, congestive heart failure, ductal dependent systemic blood flow, anemia, poor perfusion, tachypnea, big pulse and BP. Differential cyanosis in adulthood may be present with hypertension, systolic ejection murmur at left upper sternal border. Cyanotic congenital heart disease. First, tetralogy of Fallot. Most common in cyanotic congenital heart disease, 9% of total congenital heart disease. 4 common of defect: ventricular septal defect, pulmonary stenosis, overriding of aorta, right ventricular hypertrophy. Clinical manifestation: rarely pink TIF in the absence of obstruction. Cyanosis, clubbing, squatting position in walking children, paroxysmal hypercyanotic attack occur during first year, systolic ejection murmur, delayed growth and development, and single second heart sound. Diagnosis in chest X-ray: narrow base and uplifted apex, a boot or wooden shoe, decreased pulmonary vascularity, right side aortic arch in 20%, ECG and echocardiography. Complication: cerebral thrombosis in less than 2 years, brain abscess, infective endocarditis, polycythemia, and congestive heart failure in pink TIF. Treatment: severe outflow obstruction, medical prophylaxis with PGE infusion, prevent dehydration, partial exchange of transfusion, oral propanol for TAT surgery and belalotoxin and total correction. Pulmonary atresia with VSD and without VSD. Clinical manifestation: cyanosis at birth, respiratory distress, single second heart sound, and no murmurs. Diagnosis: chest X-ray, ECG, echocardiography, and treatment: PGE1 and surgery. Tricuspid atresia. In this condition, there is no tricuspid valve, therefore no blood flow from the right to atrium to the right ventricle. Blood in right atrium to foramen ovale to left atrium and left ventricle to aorta. Tricuspid atresia defect is characterized by the following: a small right ventricle, a large left ventricle, small VSD and PDA, diminished pulmonary circulation, cyanosis, bluish color of skin, and mucous membrane caused from a lack of oxygen. A surgical shunting procedure is often necessary to increase the blood flow to the lung. Clinical manifestation: cyanosis, polycythemia, easily to fatigue, biliary exertional dyspnea. Diagnosis: chest X-ray, pulmonary under circulation, ECG left axis deviation, echocardiography, treatment PGE1 and surgery. Epstein anomaly of tricuspid valve: downward displacement of tricuspid valve, right ventricle with two-part atrialized normal ventricular myocardium, abnormal tricuspid valve, huge right atrium, tricuspid regurgitation, comprised right ventricular function. Clinical manifestation: easy fatigability, cyanosis, dysarrhythmia, right to left shunt through foramen ovale, hollow systolic murmur at tricuspid area, heart failure. Diagnosis: chest X-ray, box shaped heart, ECG, and treatment PG1 and surgery. And transposition of great arteries: 5% of total congenital heart disease, ventricular arterial discordance, left ventricle to pulmonary artery, right ventricle to aorta. Clinical presentation: pure TGA with small PFO and PDA, cyanosis after birth, metabolic acidosis, weak murmur, single second heart sound, TGA with VSD, minimal cyanosis, developed heart failure in 2 to 6 months, TGA with VSD with PA, similar tetralogy of Fallot, cyanosis but no clinical heart failure. Truncus arteriosus, less than 1% of total congenital heart disease, common route between pulmonary artery and aorta. Clinical presentation: minimal cyanosis, can be developed heart failure in 1 month, cardiac murmur, pansystole, murmur at left lower sternal border, single second heart sound. Other anomalies: total anomalies: anomalous pulmonary venous return, pulmonary drainage into systemic vein, in single ventricle, no interventricular septum. Third, hypoplastic left heart syndrome, underdevelopment of left side of heart, cause atriatic, aortic or mitral orifice, non-functional left ventricle, hypoplasia of ascending aorta. Right ventricle supplies both pulmonary and systemic circulation. Persistent fetal circulation, dextroposition of heart and dextrocardia. Thank you.